The ideal approach would be to be able to prevent CMV reactivation even, not to make sure that we don't get any CMV reactivation, and to use a drug prophylactically. Of course, there are limitations. Like we want to make sure that those drugs are safe, they're non-toxic, they don't have significant interactions with medications that are being used for the transplant, such as calcineurin inhibitors, and don't cause the kind of cytopenias that you described. And of course, they're effective. There has been one drug recently approved, Letermovir, and I know you've had some experience with that. And could you describe Letermovir, its mechanism of action, and how it's been used?
Yeah, it's been an exciting time in the field of CMV and transplant. The Letermovir approval culminates a 10-year quest to find an agent that is suitable for prevention in the stem cell transplants. We know that in the solid organ transplants, valganciclovir is used routinely for CMV prevention. However, valganciclovir is not an option for stem cell transplants due to cytopenia. Letermovir is a very potent CMV-specific antiviral that has a novel mechanism of action. It inhibits the terminase. It's an enzyme of CMV that cuts the DNA at the appropriate place as the CMV DNA is produced. And it stops CMV packaging and eventually the completion of the CMV particles. Recently, a phase 3 trial was concluded with very strong results, showing that Letermovir was very effective in preventing a CMV infection when given for 14 weeks after transplant.
I know that patients can still be at risk for CMV after those 14 weeks. It's still important to monitor them after completion of Letermovir for patients who might be getting Letermovir.
So a very important manuscript with first author Dr. Marty from your institution that showed that Letermovir was extremely effective in the first 14 weeks that was given. The patients were followed subsequently through 24 weeks after transplant, so about 6 months after transplant. And we saw that a number of patients that had not developed CMV infection in the first 14 weeks, they went on to develop infection in the last part, from 3 months to 6 months after transplant. So all of these patients are routinely monitored, and so they start preemptive therapy later on.
So CMV infection, it's not just viremia that we're trying to prevent. We're obviously trying to prevent CMV disease, and I don't think in this particular manuscript there was a difference in CMV disease, but as I recall, there was a difference in mortality after transplant. Could you talk about that?
Yes, so CMV disease is pretty well prevented nowadays, and we have seen that in previous randomized trial. And in this trial, that CMV disease at 6 months was less than 2% in the Letermovir arm and in the placebo arm, showing that preemptive therapy is very effective in preventing CMV disease. Now, always in clinical trials, patients are monitored extremely well. So in the real world, perhaps the CMV disease rate at 6 months may be a little higher than 2%. But again, the rates are low in general. What's very exciting about the Letermovir trial is that there was a difference in mortality at 24 weeks and a trend for lower mortality with Letermovir at 48 weeks. So this is the first time in a randomized control setting that we see that an agent for prevention of CMV infection has an impact on mortality.